Alrighty, welcome back to Ultrasound Grand Rounds this week. Pretty excited to be back today. We had a week off last week for SAEM. I know a lot of our chief residents were down there at the Chiefs Forum at the SAEM conference, but now we're back. We're going in hard to the finish of this academic year. We have this week, next week, and the first 2 weeks of June, and then we'll be wrapping things up for this academic year for Ultrasound Grand Rounds. So it's been a good year. We've covered a lot of great topics. I haven't had a chance to kind of review all of the topics that we went over the course of the year yet. But as I do that, I'll definitely remember through all the wonderful things we talked about, from cardiac to thoracic to soft tissue to OB and various other things in between. So if you've missed any of those, definitely go back to the YouTube channel and look back. All those videos are posted. They're all available to watch and to consume. And while you're there, hit that subscribe button and the notification bell so that you can be notified every time we put out a new video. But today, we are going to continue on with this theme of OB. We've kind of had it, little bits and pieces over the course of the spring here. But today we're going to, build off of the normal OB that we did, the not quite normal OB, and now we're going to do an abnormal first trimester OB. And to do that, we have Dr. Sandy Werner back. She's going to share with us her expertise with some OB ultrasound and talk about what can go wrong in the first trimester. So Sandy, go ahead and take it away.
All right, thanks. And next week, we're doing second and third trimester, so stay tuned for that. So this is actually, I'm going to be talking about not just things that can go wrong in the first trimester, which we talked quite a bit about last week, but we're going to get into some ovaries, adnexa, ectopics. Oh my! So we're going to have some fun here. I forgot to put on my slide. I don't have any conflicts of interest, so you can I'm not getting paid high bucks for doing any of these lectures. So what we're going to do today is talk about the normal appearance of ovaries on ultrasound and some common pathology, and then some normal findings of the adnexa and pathological findings, including things that are concerning for torsion. And then we're also going to move on and talk about ectopic pregnancy. So just for definitions, ovaries, adnexa, what's what? So the ovary is the reproductive organ that produces the eggs and the female hormones. And the adnexa are the appendages of an organ, like the ovaries, fallopian tubes, and ligaments that hold the reproductive organs in place. So it's like the stuff that's between the uterus and the pelvic wall. So just a brief primer on what happens with the ovary. So you have the follicles, and one becomes larger and becomes the dominant follicle, and then it spits out the oocyte. And then it becomes a corpus luteum cyst, and then it sort of degenerates into this corpus albicans, which is kind of a white cyst. So that's what happens inside the ovary. And then this is the adnexa. So it's all the pieces, parts that really connect the uterus to the pelvic wall. So it includes the fallopian tube. Up at the top, you can see it coming out of the fundus of the uterus, and follow that down to the fimbria, which are usually somewhere close to the ovary. And if they're not, then that's when you get ectopic pregnancies that can be anywhere in the abdomen. And then you have all of the different blood vessels and the ligaments that are holding this stuff all together. So that's the difference between the actual ovary and the adnexa. The adnexa includes the whole ball of wax. So transabdominal scanning, everybody's pretty good with this and finding normal pregnancies. And you're looking at this one and you're thinking, yeah, there's something in that uterus. And, I can actually see these little structures outside, but they're kind of gray, mixed echogenicity, and I can't really see what's going on. So there might be a time where you actually want to look at the ovaries, or where you want to take a closer look at the pregnancy to see if it's viable. So I'm going to do a very brief refresher on the transvaginal approach. So the transducer, and of course you're going to use gel inside a probe cover and then sterile gel on the outside. And the approach is going to be, so the indicator will be at the 12 o'clock position, or thumbs up on that slide. And then if you were, so you're going to see the head is actually at the bottom of the ultrasound slide, and the feet or caudal are at the top. And then anterior is to the left, and posterior is to the right. And the fundus and the cervix. And this is in a normal anteverted uterus. I'm not going to cover retroverted uteruses today. And then the endometrial stripe. So, what you think you would see based on this or based on the anatomy, you put the ultrasound transducer in, and of course you think, okay, well, that's head to feet. But our ultrasound screens don't work like that. So you actually have to rotate the image in your head 90 degrees so that we get the caudal view at the top and the cephalad view at the bottom of the screen. So that's how that works. So to get to the coronal or transverse view, you turn the transducer to the 9 o'clock position, and then it kind of looks like a donut. You can have the head is again towards the bottom of the screen, right and left as labeled on this image. And then you have the myometrium and then the endometrial stripe. So that's going to be the view in the coronal look. So what do normal ovaries look like? Well, they kind of look like sort of homogeneous gray. And you have the follicles that are anechoic, and there can be of various sizes. And some people have described this as a chocolate chip cookie. And no, I did not come up with this. So you have kind of a store-bought chocolate chip cookie. There shouldn't be a huge amount of follicles in there. So that's kind of what it looks like. And just in case you're thinking about, well, what happens if it's polycystic, then you actually think about, oh, this is really a more gourmet chocolate chip cookie. So we have lots more of the chocolate chips in there. So if you see an ovary that looks like this, small follicles, but way more than you would expect, that's going to be a polycystic ovary. So we're going to move on to some different types of ovarian cysts, because you're going to see, once you get into transvaginal scanning, you're going to be seeing some of these. So we have a corpus luteum cyst, follicular cyst. You can have an endometrioma, which is one of the results of endometriosis. You can have a dermoid cyst. You can also have cysts that are para-ovarian. So they're next to the ovary, but they're not actually in it. Hemorrhagic cysts, and those hemorrhagic cysts can be follicular. They could be corpus luteal. They can just be benign cysts that bleed. And then some potentially malignant cysts. So the good thing about these cysts and masses is that over 90% are benign. So we're going to talk about simple versus complex, and then ovarian versus para-ovarian, and benign and some not so benign findings, and how to use the risk management index score. So, and then we'll also get into torsions. So this on the left is a nice, simple cyst. It's round. It has no internal echoes. It's got good posterior enhancement. There's no cobwebbing. There's no septations in this particular cyst. Compared to the one on the right, which is kind of multilocular, it's got some cobwebbing in it, and it's got multiple septi. And those are actually more concerning for malignancy. Now, keep in mind, most of these cysts are not malignant, but this is one, these are some of the features that might make you think, better have closer follow-up with this cyst when I send them to GYN. So para-ovarian cysts, they're next to the ovary, but they're not within the ovary. So you can see the ovary is on the left side of the image, and then the arrow is pointing to the para-ovarian cyst. And these folks have come up with like the beak sign. So it's like if it's not part of the ovary, you can actually see a sort of distinct border, and they call that the beak sign. These are almost always benign tumors. Another thing you can do is actually put some transducer pressure right at the intersection of the ovary and the cyst. And if they separate with that pressure, that's another indication that it's para-ovarian. And this is also really important if you're looking at what might be an ectopic pregnancy versus a corpus luteal cyst, because you'll want to be able to see if that what you think is an ectopic is actually separating from the ovary when you press down on it. So this is an example, these nice simple cysts, follicular cysts. This is, this is the dominant cyst. It's become the follicular cyst. Sometimes these can become quite large, and sometimes they can actually bleed. So that's just like a normal follicular cyst. And those are pretty easy. They're simple. They can be any size, but they look very similar. Simple cysts. The corpus luteum cyst, however, these are interesting because it goes through several phases. So it may start out looking, kind of simple, and then it may, as it involutes, it may start to look more complex. It may have a thick rind around the interior. So they're really variable in appearance. So this is a couple of examples. The one on the left is really the first really kind of bizarre corpus luteum cyst I had seen, and I knew there was a chance of a ovarian ectopic. So I actually took this, and this was back in the day when we were doing paper prints. I took this to our radiologist, and they looked at it and they said, "Oh, it's a corpus luteum cyst." And then they said, "But they should probably have a repeat ultrasound in 48 hours to make sure." So that made me feel kind of good. And then the image on the right, you can see that the corpus luteum has actually become almost solid. And then it's just going to kind of shrink down and become that corpus albicans, and then it will go away. So those can be a little more difficult. So I have a bunch of cases that are interspersed in here. So this is a 21-year-old female, G2P1, at approximately 8 weeks. And in fact, you do a transabdominal ultrasound, and there's a happy little 8-week IUP. But, she has significant tenderness on the left, and you couldn't really get a good view of the ovary. So you're saying, well, let's go ahead and actually take a look with transvaginally. And there is that left adnexa. And as you scroll through it, you can see that there's a thick rind of ovarian tissue around it. And then there's also hemorrhage outside of it. So we have the ovarian tissue, the cyst, and then this is actually free fluid outside. So this is a corpus luteal cyst that has actually become hemorrhagic. And in fact, when you press the transducer on the cyst, that is exactly where it hurts. And you check for free fluid everywhere else. There's none. She's hemodynamically stable. And rather than waiting 4 hours for my transvaginal ultrasound by radiology, I can actually get her home with some pain meds and OB follow-up. So very, very helpful. So now I'm going to talk a little bit about more complex or solid type cysts. So this one, you can see it actually it's quite echogenic. It has some solid component to it. It's kind of very strange looking. And this is a dermoid or a teratoma. And these are almost always benign. And they're composed of, it's like a germ cell tumor gone crazy. So they usually contain skin, fat, teeth, hair. For those of you who are eating lunch, I apologize, but this is what they look like on the inside. So you can see this actually contains something that looks like a tooth, maybe some bone, definitely some fat, and quite a bit of hair. And so typically, if you're over 45, if it's rapidly growing, or if it's already larger than 10 centimeters, and these things can get big, those have a higher potential for malignancy. Typically, if you find a dermoid, it's a 6 months follow-up ultrasound, and as long as it's not growing, then you don't really need any other follow-up with these. So if you diagnose this in your ED, you want them to get a repeat ultrasound. If it's not growing, typically, then you don't need any more follow-up. So this is a type of cyst that you might see in somebody who has a history of endometriosis. So, and it's actually endometrial uterine tissue that's planted. It can be anywhere outside, but one of the common places is that it's actually within the ovary. So you have kind of a rind of ovary around it, and then you have this, it's called a chocolate cyst, because inside of it looks like, kind of dark clotted blood. And that's a pretty common finding. Somebody who's had difficulty with fertility, they have monthly abdominal pain, their HCG is pregnant, and you find the pregnancy, but you also find something that looks like this, and that would be an endometrial cyst or an endometrioma. So another case, this is a G2, P2, 36-year-old female. She's actually got no GI or GU symptoms. HCG is negative, but she actually has like this this palpable right lower quadrant mass. And so you decide to go ahead and scan. And in fact, it's big enough that you can just scan transabdominally. And you can tell this is a transabdominal scan because of the footprint. So on the transvaginal, you're going to have a bit more of a deep curve of a footprint and a smaller footprint. So this is the transabdominal. If it's not labeled, you can figure it out just by looking at the footprint of the ultrasound. So scanning through, you can see there's some funky kind of bright echoes, and then at the end, there's some solid matter in there. So that's the sagittal view. And that's maybe a little concerning. And then the transverse view, again, scanning through. Solid lesions, those weird little echoes. And then at the end, there's actually a little bit of free fluid. So this should make you a bit more concerned because it has some of the features of a malignant cyst. So if you're thinking about malignancy, there's actually a scoring tool you can use, but you do need the CA 125 because that's part of the calculation. So if you have somebody with multilocular cyst, solid areas, METs, well, that one's pretty obvious. If they have ascites or bilateral lesions, if there's 0 of those points, there's no features and it's 0. If there's one feature, say you had solid lesions in there, then it's going to give you 1 point, but 3 points if you've got 2 to 5 features. So if you have a solid area and you also have some free fluid, that gives you 2 features, and that would give you 3 points. It's higher risk if you're postmenopausal, so you get 1 point for premenopausal and 3 points for postmenopausal. And then you actually need to send the cancer marker. So, this is somebody that I would scan, and I would be really concerned about that cyst, and I would probably go ahead and send the cancer tumor. I might not wait for it to get back, but I would certainly consult OB and have them get close follow-up with this patient so that they can determine, if it's moderate risk, they may follow. If it's high risk, so you have if you have a significantly elevated CA to 125, those are really high risk, and typically they go and get a laparotomy. And this patient actually was. It wasn't actually a patient. It was somebody. We were one of our course instructors, and she went immediately to her OB-GYN, and it was an ovarian cancer in very early stages. So by finding it by us doing the ultrasound, we actually diagnosed her much earlier than she probably otherwise would have been diagnosed. So we've talked about the most common ovarian cysts, the corpus luteum, which is variable in appearance and can be tricky. The follicular cysts, which are usually simple. They can be very large. Often they're just a couple of centimeters. The endometrioma, which is just a form of endometriosis. There's also the dermoid cyst, which is sort of, it's also called a teratoma. Some people call them monster cysts, which, as you saw from the inside, is not a not a bad name. And then we have para-ovarian cysts, hemorrhagic cysts, and really those can be, the follicular cysts. They could be a corpus luteum cyst. They could just be a simple cyst that turns hemorrhagic. And then some features that are more indicative of malignant cysts. So that's my summary for ovarian pathology. And, typically if you're scanning in the ED and somebody's got a cyst, you do want them to see OB or gynecology just for a follow-up. Make sure they get a repeat ultrasound at some point. But for some of these, like if it's a follicular cyst, they really don't need to go and have any additional follow-up from that. So simple cysts really require no follow-up. So this is another case. We have a 28-year-old female, G3, P2, maybe she's 10 weeks by LMP, and she has sudden onset of severe left-sided abdominal pain. It started about 4 hours ago, and it's kind of waxing and waning. It gets really severe, and when it's really severe, she gets diaphoretic, she gets nausea and vomiting, and her HCG is positive. So, of course, you're thinking, okay, this could be an ectopic pregnancy. It could be a cyst. It could be, I don't know, maybe ovarian torsion. And so we're going to look. We find a happy IUP, indeed, at about 9 weeks. But then next to the IUP, and this is, again, we're seeing this transabdominally because it's very large. You can see there's a really large cyst, and it's kind of got two components to it, but it's 8.5 or 8.25 centimeters by 5 centimeters. So that alone should be concerning for torsion. And we put some color flow on it. And you don't really see any color flow within the ovary. Now, I will tell you that this is not a foolproof way of diagnosing ovarian torsion because the ovary has two blood supplies, and it may take multiple turns for it to completely lose supply. So you can also look at the relative blood flow in the two ovaries to figure out if there's a difference in the arterial and the venous flow. You can also look at the resistive index. If it's greater than 0.7, that's indicative of impaired blood flow. But there was one study that looked at using Doppler, and basically they found that once the ovary had no Doppler flow, this was a pretty small study of about 20 patients, and the 6 that had absolutely no Doppler flow, the ovary was already dead. So that should not be a deciding factor for you because if you're only torsed 1.5 times around, you may have blood flow. And some people with normal blood flow but clinical appearance of torsion and a large cyst actually have had torsion on surgery. So what happens with torsion, and again, we're involving the entire adnexa, basically stuff gets twisted. So the fallopian tubes, the blood vessels, and they get twisted around between the ovary, and they can go up to 4 full revolutions. And so you get this mass, and the ovary can also become malpositioned because as this fallopian tube and everything else twists, it may get closer to the uterus, as you can see on the lower image, and it also may come in front of or posterior to the uterus. So an abnormal position is also something that should key you into that. And then just as a reminder, the ovary actually has 2 blood supplies. There's blood from the ovarian artery that comes right off the aorta, and then there's also blood flow from the uterine artery. So as you're looking at blood flow, there may be some in there, but you may have cut off one artery, so it's suboptimal flow. And then at pathology, this is kind of what it looks like. So it's a big knotted mass that you can unwind and usually if you take it out it's dead. But there has been quite a bit of success with actually detorsing these and watching them for a little while, and they become pink and healthy, and those ovaries are generally left in. So the time to death for ovaries from torsion is not as specific or certain as testicular torsion, which is pretty much after 12 to 24 hours. It's dead. In ovarian torsion, though, it can be 6 hours. It can be days if there's intermittent torsion. If there's partial blood flow, it can actually take 3 or 4 days for the ovary to die. So typically when they go in, if it's not obviously dead, they will detors and see if it reperfuses, and those ovaries are left in. So some common findings of the ovary itself. You'll notice that this one is edematous. It's large, and anything larger than 5 centimeters in diameter in any direction, whether it's just the ovary or whether it's the ovary and a cyst or a mass, is at higher risk for torsion. You can have torsion with smaller ovaries or cysts, but it's far less likely. So this ovary is big, and you'll notice there's a lot of edema, and all of the follicles are pushed to the side, and they're kind of stretched out a little bit. So that's kind of an ovary that should be concerning to you for potential torsion, especially in the right clinical setting. So there's other things you can look at. There's something called the whirlpool sign, which is you can actually see on grayscale, you can see that there's this kind of a whirlpool-looking sign, and you can put color flow on it, although actually because of if there's lack of flow in there, you may not even see color flow. So, but this sign is difficult to find. It's not always prevalent. If you're not doing a lot of these, it's not always present. And if you're not doing a lot of these, it's certainly not something that you want to rely upon. So concerning for torsion, ovaries, mass, the whole picture, the whole mass, greater than 5 centimeters in diameter, any direction. Abnormal position of the ovary. If you have an ovary that's large and is sitting like on top of the uterus or is behind it or in front of it or very close to it, that should make you concerned for torsion in the right clinical setting. And then edematous ovary with follicles pushed laterally and kind of follicles look kind of stretched out. And then, of course, the blood flow, which people want to rely on, but normal blood flow does not rule out torsion. So the gold standard for diagnosis is surgical. So when you present these patients to an OB/GYN consult, you have to make clear the clinical situation. And yes, there's a role for ultrasound, but it's not perfect. All right, so reviewing again our Adnexa. We also have the fallopian tube, and those fallopian tubes are kind of long and skinny, and they can actually become filled with fluid. So you can have hydrosalpinx. You can also have a pyosalpinx. So with the hydrosalpinx, and this can happen from, it's usually a delayed, like after a chlamydia or some other pelvic infection. So as you're looking at these, you'll see that there's incomplete septa. They don't have any blood flow in them. You can see there's, they look kind of like a snake, and that's a hydrosalpinx. As you're going back to our ovary here, there's the oocyte, and we all expect that it's going to make it out and connect up with the sperm, and they're going to travel down the tube, and they're going to implant in exactly the right place, except that that ovary and that sperm, they don't really have a brain cell between them. So how they figure out exactly where the right home is pretty amazing that it occurs at all. And sometimes those fimbria are not like ready to catch the ovary. So it may wind up going astray. And if the sperm happens to go through the tube, then you're kind of in trouble. So ectopics actually can be many, many places. So the most common are tubal, and that's 95% of your ectopics will be somewhere within the tube. So they might be interstitial or, right where the uterus meets the tube, and those can be scary because they can get to be very large, 12, 13 weeks before they actually rupture. And if you don't correctly look at the uterus in both sagittal and coronal planes, you can actually miss these because they look kind of normal on a sagittal plane. And then the isthmus of the tube, about 12%. Ampullary is by far the largest area. And then the fimbrial ones are like 11%. And I missed one that was probably fimbrial a number of years ago because it wasn't really between the ovary and the uterus. It was lateral to it. And my guess was that it was in the tube and it was like right at the fimbria or lateral aspect. So I didn't go beyond and look for it. So you can have an ectopic within the ovary itself. You can have them out in the abdomen, very rare. Super rare, the intramural, so if it's actually an ectopic within the wall of the uterus, that is super, super rare, less than 1%. So if you're playing Jeopardy and the answer is what's the most rare form of ectopic, it would be the intramural. C-section scars, as C-sections have become more common, it's been found that you can have an implantation that's actually within the scar, and that since it's scar tissue, it may not hold together so well, and these are at high risk for rupture or often just fetal demise. And then a cervical ectopic, again, less than 1%, where they make it all the way down that far. So this is, I'm going to give you a couple examples of different types of ectopics, and we'll go through a few cases. So this is from Zonari, and this is actually a live cornual or interstitial pregnancy. It's a little hard to see, but that's actually a little fetus with a heartbeat. And you can see that that's actually quite large, but it's way off to the side of the uterus. So C-section scars, I've only seen one of these. And it's right where it implants itself right where the incision for the C-section was. So they're going to be lower in the uterus. So they may be lower in the mid-uterus, just not quite all the way down to the cervix. And then, of course, typically they're going to be anterior. And you may actually be able to see the C-section scar. But you'll notice that it's not really, the endometrial stripe itself is still pretty thin. So it's not a nice wide endometrial stripe with the pregnancy coming off of it. So anybody who's had prior C-sections, you might think about a C-section scar ectopic. And this is a case of a cervical pregnancy. These are, again, really rare. And this patient, actually, I got a call from one of our OB GYN doctors who said, there's a woman sitting out in your waiting room. And he said, she won't wait very long. She's very impatient, but I think she has a cervical ectopic because he had seen a radiology ultrasound from several days before. And he said, I need you to get her back, and can you just send her up to me? And I said, okay, fine, but only if you share your images with me. So so the transabdominal view, you can see that there's a uterus, but the cervix looks kind of large and echogenic, and it looks like there's actually something in it. And sure enough, when you look transvaginally, so the sagittal view transvaginally, you can see that there's a yolk sac. And take a closer look, there's actually a fetus with a heartbeat. So those are very problematic because when they rupture, they just bleed like crazy, and there's very, very hard to get a hold of and actually get do a hysterectomy quickly enough to save the mother. However, if they're small like this, they're amenable to treatment chemically. And in this particular case, the doc used potassium. He just injected potassium right into the ectopic. And that can also be done with methotrexate. So cervical ectopics, very rare. Don't miss one if you happen to see it. So another case, a 38-year-old G6P5 female at approximately 8 weeks by LMP. She's got like gradually worsening right lower quadrant pain, but it seemed like it was worse this morning. She's a little bit tacky, but blood pressure is okay and has a positive HCG. So on scanning, you do your transabdominal scan and, oh, wait just a minute. Wait. There's something not quite right here. And so I'm going to look transverse and, I can see the uterus and it looks like maybe there's some free fluid back there. And it also looks like there's this thing outside of the uterus or right next to the uterus. So lots of free fluid down here. And then, what's going on there? Well, that's a nice ectopic pregnancy. So what are the risk factors for an ectopic? The number one is previous ectopic. So if they've had one before, they're more likely to get one again. Smoking, maternal age greater than 35, and then history of PID, sexually transmitted infections, particularly chlamydia, and then blocked fallopian tubes from prior infection or from scar tissue or whatever else. And then endometriosis, and these are the kind of the most, the highest level risk factors. There's a bunch of other ones that are a little bit less predictive of the risk. So typically the findings, often we don't see a definite ectopic. So if you see a gestational sac with a yolk sac or a fetus outside the uterus, it's a definite ectopic. But other findings that you may see are just likely to be ectopic. So a tubal ring. So you have the ovary, you have the uterus, and you have this ring in between. That's highly suspicious for an ectopic pregnancy. Adnexal masses, complex adnexal masses in folks who are pregnant, have empty uteruses, highly suspicious for ectopic. Echogenic fluid in the cul-de-sac, which is indicative of clotted blood. Now, a small amount of simple fluid in the cul-de-sac is considered normal, but once you see some clotted blood in there, you should be thinking, what's going on? There's nothing in the uterus, but I've got clotted blood in the cul-de-sac. And yes, there are other things that could cause that. It could have been from a ruptured cyst as well. But if the HCG is positive, that should be leading you more towards thinking it's an ectopic. And then an empty uterus with a thick endometrium or some nonspecific fluid collection and a, quote, high HCG. And you'll notice I haven't really talked about the use of HCG in scanning because, we can use these levels, and there used to be, a discriminatory zone where our ultrasound folks wouldn't even scan a patient if they had a low HCG because they said, we're not going to see the pregnancy anyway. But some ectopics can have quite low HCGs. The lowest one I've ever seen is 12, and I have one a little later in the slideshow with also a very low HCG. So we talked about this a little bit last week, which is the pregnancy of unknown location. So if you do your transabdominal, you don't see anything, you move on to the transvaginal. And if there's an IUP, you have to consider the heterotopic risks. And then there might be other ovarian pathology, or maybe this is appendicitis. I mean, if they have mild abdominal tenderness, probably not so worried. But if it's severe, brought them to the ED, you kind of want to start thinking about what else might be going on. So a low HCG, kind of less than about 2,000, and no free fluid and normal adnexa, so you don't see anything that makes you suspicious for an ectopic, these folks need to have a repeat HCG and potentially a repeat ultrasound in 48 hours to make sure that it's just a developing pregnancy that you haven't seen yet on ultrasound, or that the ectopic you just weren't able to see at that point. If they have a high HCG, and that's typically described as over 1 to 2,000, or a free fluid or an adnexal mass, you need to have GYN come and see them. And then obviously, if you discover the ectopic pregnancy, then you get GYN down and for definitive management. And then, of course, if you find fetal demise, that's going to be GYN follow-up. So this is a probable ectopic, and you can see, actually my uterus label is slightly off. You can see there's a tubal ring. The uterus is actually slightly to the right, but you can see that there's actually a ring. The ovary is to the left, the uterus is to the right, and there's this ring that has an anechoic center and kind of a thick rind around it, and it's separate from the ovary and the uterus. Now, this may go on to develop a yolk sac, and then you'd have a definitive ectopic. And there's something called a ring of fire. So if you put color flow on this, it's going to be, it will probably show you a lot of flow, but the ring of fire can also be seen with other adnexal lesions. So that's not something that you actually want to rely upon. So here's an example of just a complex mass. So you can actually see, here's the fallopian tube, and then there's this mass in here. And actually, if you look a little closer, you'll notice the chocolate chip cookie of the ovary right there. And a little bit closer, changing your angle, you can actually see that there is a tubal ring there. And actually, going even closer, you can see what looks like a yolk sac. So complex masses, explore them, but you may not be able to find, especially if it's already ruptured, you may not be able to find that ectopic pregnancy. And then any kind of fluid, so complex fluid is hemoperitoneum until proven otherwise. And we actually can measure how much the kind of the quantification of the amount of fluid. And a small amount is kind of the cervix up to 1/3 of the posterior aspect of the uterus. Moderate is up to 2/3 of the uterus, and then large is basically encompassing the entire uterus. So here is a transvaginal scan. We're sagittal, and we have some free fluid there. But if you really look in the posterior cul-de-sac, and this, you probably won't even see this at all on your transabdominal scanning because we're really posterior. There's a bunch of clot there. So that is, it's hemoperitoneum until proven otherwise. And this is another example. So there's nothing that looks like an IUP in there, and there's a lot of free fluid. And then there's also a lot of clot. So this should be highly concerning for an ectopic pregnancy. And then another thing to check is the Morrison's pouch view. This in itself isn't diagnostic, but if you have enough free fluid that it's actually getting up to Morrison's pouch, it's highly predictive of a patient who needs to go to the OR right away. And usually OB will take them if without a whole lot of fuss if they have that much free fluid, because there's absolutely no way that's going to be treated by methotrexate. So this is a case that I just had pretty recently. And a patient came in, hypotensive tachycardic, wound up in ED West, which is our low acuity side somehow. And I put probe on. I didn't have an HCG yet because she hadn't been able to pee, and she's a difficult stick for an IV. So I just went ahead and put the probe on. And as you can see, there's a whole lot of fluid and some clot above the uterus. So kind of a problem. And just scanning through, there's also this weird looking mass there. And kind of strange. And then the transverse view, just kind of a mass. I'm not really sure exactly what's going on there. And actually, I think, maybe there's a little yolk sac in there. I'm not quite sure. And then I went up to take a look at Morrison's pouch, and there was a lot of free fluid there. So I called OB without even having an HCG and gave them the story. And basically the resident was like, well, we'll wait for the HCG to come back. But then the attendant came down and said, it doesn't really matter. She has to go to the OR. So eventually we got the HCG back. And in fact, it was actually a ruptured ovarian cyst that had caused this much bleeding. So it's not always an ectopic, but that would be a high likelihood. And if there's enough blood to get up to Morrison's pouch, they're going to the OR anyway. So another case, 40-year-old female, G4, P3, which she actually discovered that she was pregnant based on the urine that was collected in triage. And she's been having some left lower quadrant pelvic pain. Nothing severe, but it's kind of just been gradually getting worse. And the transabdominal ultrasound shows no IUP. The transvaginal ultrasound shows no IUP. So here's your ultrasound. Oh, I thought I had this was video. Oh, this is. So you can see that the endometrial stripe is slightly thickened and there's a little bit of free fluid within the endometrium, but it's not eccentric and it's not it's not definitely a gestational sac there. It's not really surrounded by the endometrium. It's just this little bit of free fluid. So we're going to take a better look at the uterus transvaginally, coronally. You can see nothing in the uterus. Again, that free fluid, slightly widened endometrial stripe. Okay, so we're looking again. And wait, I can't see on my video screen very well, but you should be able to see both of the adnexa. The left one is down here, and then the right one is up here, and it looks slightly enlarged. So we're going to take a closer look at that. So we're scanning through. The ovary was pretty close to the cervix. There's the ovary. But what was this in the middle? What is that? That is a little tubal ring. So slightly concerning. Measure it out. It's pretty small, but her HCG is positive. There's something going on there. Diagnosis is an ectopic pregnancy. Her beta HCG was 51, so very, very low. And the patient was really surprised because she'd had a tubal ligation 9 years ago. So it is still possible to get an ectopic pregnancy. In fact, if you've had a tubal ligation, and those are basically blocking of your fallopian tubes, if you have a positive HCG, it's most likely that you have an ectopic pregnancy. And this one was actually amenable to treatment with methotrexate. And I'll go over that criteria in a few minutes. So 39-year-old female, new case, G4, P3, 7 weeks by LMP, right lower quadrant pelvic pain, positive HCG. We're scanning. We're already transvaginal here. And, there's a happy little IUP there. But she's still got this pain, and it's fairly significant. And you can actually see here the adnexa is on the left side, and then the right one is coming in right over here. So again, we can see that nice yolk sac, see that right adnexa. Let's take a little closer look there. There's actually, we're looking at the right ovary here. So you can see the ovary, the uterus. Okay, that doesn't look terrible. But, there's something bothering me here. I'm going to take a look. And this little thing right here is bothering me. And I'm squishing it. And I'm actually seeing this is the ovary, and this is this ring that I'm seeing. And it's separating when I press down on it. So although she has an IUP, I'm thinking this is a heterotopic. OB is thinking not. But they decide to take her to the OR because she does have some free fluid. There's some clot at the cervix. So she goes to the OR, and she actually has a heterotopic pregnancy. So how prevalent are they? The old literature says 1 in 30,000, but the more recent literature within the last 10 years says about 1 in 4,000. And it's 1 in 100 to 500 for infertility patients. So your risk factors, PID, STIs, infertility treatment, maternal age greater than 35, and a history of endometriosis. So how do you treat these things? Well, medical versus surgical. So methotrexate would be the best way because you actually preserve the tube. If they're hemodynamically stable, they don't have any evidence of tubal rupture, no hemoperitoneum. The adnexal mass has a diameter less than or equal to 5 centimeters, and some institutions go up to 6 or 7 centimeters. And then the last criteria is if they've had amenorrhea for less than about 6 weeks, and they have HCG levels that are lower than 10,000. And again, there's going to be some institutional variation on these, but that's the common ACOG recommendation. So we covered a lot. I could have actually done a separate lecture on each of these. So once you do transvaginal scanning, you'll probably want to do some more studying. But we talked about some sonographic appearance of normal ovaries and common pathological findings, most of which are benign. And we went through some findings of the adnexa, including findings concerning for torsion and also hydrosalpinx. And then we looked at some ectopic pregnancies and some factors for those.
Well, thank you, Sandy. I appreciate you presenting that lecture. Is very helpful and very comprehensive about all the abnormal things that you might be faced with. And I know as I've worked in the department, as I've talked to some of our faculty, I think one of the barriers for our faculty doing more first trimester studies is not I have a nice, happy, healthy 9-week or IUP that's waving at me. It's what if I don't have that, and what if I actually have an ectopic, and what if I miss the ectopic? And so I think being able to see some examples, to look at that, even talk about some various types of cysts that we might run into, is really helpful as we think through how to do our first trimester study and what are the things we want to look for, that IUP, but also some of the pitfalls that we could run into as we're scanning those. So, Sandy, thank you so much for coming and presenting that. I think it was really helpful. So, with that said, we're going to wrap things up here today. We have a couple, like I said, at the beginning, we have a couple more weeks. Pretty excited. We're going to have second and third trimester OB emergencies next week. So you're definitely going to want to join us for that. One of our OB docs is going to come and talk to us. I know we don't see a ton of them in the ER just because our protocol is to get those up and out of the department as rapidly as possible. So OB is going to come and talk about those and some things that we may want to look for in our second, third trimester studies, if you have the patient in the emergency department with, presenting with emergency level complaints. So you definitely won't want to miss that. And then, we have some follow-on lectures in the following week. So with that said, we'll wrap here. Thank you guys for joining us, for being part of this forum. As always, hit that subscribe button on the YouTube channel, follow us over there, and get caught up on some of the other videos we've produced. And we'll see you next week. Thanks. Bye.